Okay, great. Welcome everybody. I see that recording started, so we'll commence now with the governing body meeting. Welcome everyone, and just really to start through the agenda, I've not received any apologies today. If anybody knows of any, please let me know, but I've not received any formal apologies, so I think we've got a full house. And then moving on to the declarations of interest for members. This is the opportunity really, if anyone has a declaration of interest they wish to make, in addition to that which we have on our declarations of interest register, particularly anything pertinent to today's agenda, then now's the opportunity to raise that. Excellent. Okay, thank you. So just introductory comments. Welcome firstly to everyone who's joining us on live streaming or broadcast. We've got a full agenda today. It reflects upon our transition to a new CCG, including strategies and policies. It includes a focus on, as always, quality, performance and finances. A particularly important paper of the niche consultancy report. We focus on, again, on our integrating our work with the wider system and the ICS. A paper we'll receive of a new committee being formed to ensure full involvement of the public in our commissioning processes. So very much an open and transparent meeting, facing head on the challenges that we have, but also with optimism that we're part of a system that's determined to work together for better integrated care. And I'd like to mention that today is International Nurses Day, and really a tribute to all nurses for the phenomenal work that they've done over in the past year and a bit, really, well, more than that, but particularly in the past year for the pandemic. International Nurses Day marks the birthday of Florence Nightingale in 1820, and this year we've seen hospitals named, Nightingale hospitals, and again recognising an individual, but also the vital contribution of all our nurses across our system in the NHS, covering our acute care, mental health nurses, nurses in the social care system. And so, yeah, I think we wish to put on record collectively an enormous thanks to the work you do day in, day out. And of course, there are nurses on our board and nurses that take leadership roles, nurses very much in the thick of things with direct-to-patient care as well. And so, yeah, putting on record our genuine thanks and appreciation. This has been a tremendously difficult year, but without nurses, we'd have been very stuck. Thank you. Okay, so without further ado, Claire.
Thanks very much, John. I think first thing for me to say is what a whirlwind 6 weeks it's been. So stepping up into post on the 1st of April, I feel like I've blinked and we're already well into May. I think that's quite reflective as well at the pace of work that's going on in the system at the moment and the hard work that's going in, not just in the CCG, but across the broader system to address all of the things that we need to focus on at the moment. So certainly my reflections in terms of my accountable officers report this month are very much on the key things that I'll give you headlines of, but I know you'll get more of a sense and a flavour of what's going on as we work our way through the agenda, because when we talk about the work that's happening in the system, this is our work too, and it's what we as a team are very much involved in. So just a few things for me, just points of note really for governing body members. First of all, we had our ICS board on the 28th of April. For those of you that weren't there, it was quite a packed agenda, again, as I say, reflective of all the work that's happening at the moment. But for me, I felt the transition from that shadow position into a formal board. I think we're going to now drop into a really good drumbeat of activities for the system, and we've got some real opportunity to help shape our work moving forward through that board. So we are going to be receiving their regular reports on the pledges for the system. I apologise, that's my cat. The pledges for the system, and also the work that the subcommittees of that board are now doing. So we've heard before how we've established things like a quality and safety committee that I know John chairs. We've got a risk committee, a sustainability committee, and we can see the route now for those reports going through to that board. So I'm really heartened by the progress we're making in those areas. Financial recovery, our big ticket areas to drive sustainability are real key areas of focus. And as I've said, you're going to hear about bits of that as we work our way through the agenda, because our teams are intrinsically embedded into that work programme that's happening. And for me, I'm seeing really positive things. We've got great work now starting to develop across multidisciplinary teams, across various organisations. And I know that's something that we as a governing body and 2 individual CCG governing bodies have been looking for some time. So I think that's really good. And I can't not mention the restoration and recovery work that's going on. So lots of planning happening at the moment for how we do recover our services for patients, and we start to address that elective list that is going to take, as we know, quite some time to work through. I wanted to touch on the COVID situation, but the vaccine programme in particular. Again, some really good news for our system. Our prevalence rates remain low. We have minimal COVID positive patients in hospital, which is what's going to help us really start to open up that elective activity, albeit I know it's still going to be a challenge with all the social distancing measures and the things that we have to deal with. That said, I think our message is still very clear. We mustn't be complacent. We still have to observe the rules, the hands, face, space, and we need to keep continually encouraging our population to make sure that they take up that vaccination when they're offered it, and also return and have that second dose, which is really, really important. We're offering all of the current delivery models in line with the JCVI guidance, and we're planning in earnest at the moment for phase 3. So not a lot to say about that at the moment, but you'll hear more about that over coming months. And the only other thing just to touch on for this particular item is just to give you a very quick update on our move to Ptarmigan House. So you'll recall that we are planning to decant staff out of William Farr House. We've had a little bit of slippage in the timescales, nothing too fundamental. We've just got some IT kits stuck that can't be delivered as quickly as we would have liked, but that's not stopping us in terms of our preparation for that move. And really importantly, we're working with our staff on our broader agile working policy. So we're taking some learning from the last 12 months and how we've mobilised our teams during COVID, and
I've just lost you, Claire. You've just gone on to mute.
Oh, I do apologise. I don't know what happened there. But yeah, so agile working, definitely the way forward. The staff are very keen. So we're looking to see how we can support them in doing that. That's me. Thanks, John.
Great. Thanks very much, Claire. Okay, so moving on to minutes from our previous meetings. Firstly, minutes from the meeting from our committees in common from the 10th of March 21. I know that I had just a couple of actions, things from those minutes. On page 3, I noticed that there was the plan for an update to come to board in the future from the independent inquiry for child exploitation for Telford. I gathered Zena and Dave were meeting with the chair, and that we would receive an date at some point. So Zena, just wondering whether, I don't see it as an action, but whether there's a plan for that to come back to us at some point.
So there won't be a report from that, John. This is part of a series of engagement meetings that we have with the chair of that inquiry, and Dave Evans and myself did meet with the chair of that group and just provided some background information. So it's really, they're still at the stage of information gathering and trying to probably put together in their minds how health is organised, and we went as far back as PCT days and the transfer of responsibility. So it was a bit of scene setting for them, and you know, we continue to work with them very collaboratively and provide information as requested, and that's an ongoing process for us.
Okay, thanks. And if anything significant relevant to the board were to arise from that, Zena, if you can bring that back to us, that would be fine. But that's helpful. Thank you. Mike.
Morning. Something silly. People present. I note that some people who were on the joint committee didn't seem to be mentioned on the present from on that date, and I seem to be missing from the one for the 24th. I thought I was there. I may be wrong. It could have been a doppelganger, and I'm having an out of life experience thinking that I'm at meetings when I'm not. But just wanted to check that people are being recorded as being there, as Fiona and Rachel don't seem to be mentioned there, and the only absentee they mention is Martin. So I just wanted to make sure that we are recording the right people that are actually at the meetings.
Thank you, Mike. If we'll come on to the 24th, for the minutes of the 10th of March, if anyone who was present who hasn't been recorded as being present, can they just let us know now? Audrey, was that the point you wish to raise as well? Oh, you're on mute, sorry.
Sorry. Very quick question for Zena from the minutes, if that's okay, please. CNST was mentioned, Zena, that the trust is working towards it. Is that going to come back to another meeting there, how maternity is progressing?
So that would be covered ordinarily in our quarterly maternity update reports, Audrey. They do go to the local maternity and neonatal system programme board in any case. It's very much a live piece of work at the moment, as you can imagine, with the deadlines looming. So it's all being attended to and will be covered in a quarterly report.
Okay, lovely. Just wondered that. Thank you.
And Fiona.
Hi, John. Just to say, I was at that meeting on the Wednesday, the 10th of March, and I'm not on the list.
Thank you. We'll add your presence to that list. Thank you. Excellent. Lynn?
Just a small correction on page 4 under an action, which was 2101-010. Performance quality report. The hot topic was on neurology and not urology.
Yeah, I'd spotted that. Thanks, Lynn. We can correct that. Excellent. Rachel.
Yeah, I was also present on the 10th of March. I don't think I've been absent from any of these meetings.
That's smashing. Thanks, Rachel. And Zena.
Yes, so my amends are relating to the content, John, and apologies if you're intending to go through page by page. I can pick them up in that order. No. Okay, so at page section 9.14 and 9.16, the abbreviation is recorded incorrectly. It's listed as commissioning quality review meetings, and they're clinical quality review meetings, often abbreviated to CQRMs, just for clarity on that one. Yeah. And then just moving down to section 11.18. Yeah. And I just need to get to that one. This is the last sentence. And the policy that I'm referring to there is the values-based commissioning policy. I think the limited clinical values policy was its predecessor name. So it's the CCG policy called values-based commissioning.
Sorry, which section was that, Zena? I missed that.
It was 11.18.
Okay, and the correction is that it is the 1118.
The policy I was referring to is the values-based commissioning policy.
Thank you. I don't actually see that under 1118 in my minutes. Have I got the right section?
Let me just find
Limited clinical value, John.
It used to be called the POLC V, the Procedures of Limited
Yeah.
Clinical Value, and that was the older title.
Been discussed with SAF and alongside the limited clinical value.
Perfect, we'll correct that. Thank you, Zena. Excellent. Super, so those are the minutes for the 10th of March. Moving on, if anyone else had anything from the 10th. Lynn, is that a historical hand or another point? Thanks, Lynn. Okay, Zena, historical or new? Historical. Okay, minutes for the 24th of March. Okay, if we agree those to be an accurate record, that's fine, thank you. And any feedback from the minutes of the 14th of April? No, that's great. So if we're in agreement that the minutes therefore form an accurate record with the corrections that have been noted. So moving on to matters arising. Certainly a good list of matters arising from the 10th of March. If we go through those, firstly, the Partnership Board terms of reference and feedback to the governing body and Health Watch following the Partnership Board meetings. Claire, it says next meeting. I was just wondering whether I'm not sure that I saw it in today's agenda.
No, sorry, John, that's kind of missed my radar, I think. I'll get those circulated because I presume that's the Children and Young People's Partnership Board we were talking about.
I believe so, yeah.
Yeah, I'll get those done now. I'll get them to Sandra so she can get them circulated.
Thank you very much. And then the next item has been completed, the amendments in terms of matters arising for Dave Evans. First is completed. The second item, the draft ICS, I mean, I think history has overtaken us here, hasn't it? Because the ICS application has now been approved. Is there anything outstanding on those two items? Claire Skidmore, I'm looking to you on this one.
Yeah, so NHS have set up a new process now for all systems to move through the application, and very similar to the process we've just been through for CCG merger. So quite a systematic checklist for us to work through and provide evidence that we're taking all the steps that are required. So not a lot to update on at the moment, but that will grow over time. They're starting to publish the timescales really for when key guidance will be issued, so we'll brief as those things come through.
Thank you, we'll capture that, that's great. Moving on to the next item regarding ambulance crew on scene timings. Julie, I know that we've got a reference to handover delays of over 1 hour in the performance reports later. Regarding the specifics of that action.
As I say, as we know, unfortunately, we've had some unexpected illness in the team, and we've been able to complete that for today's meeting. But what I just want to ask the governing body, I should be able to bring the paper through, and obviously conscious that we don't meet we meet every other month. Yes. So if it's acceptable to the governing body, I will have that through to the Quality and Performance Committee in June, which then means they can advise through the notes of that meeting that we've dealt with that action, so that it's not delayed for a full 2 months.
That's excellent. Thank you, Julie. And yes, we recognise the unexpected severe illness that you had with a member of your team, and that's entirely understandable, and wish him very well. So thank you. Okay. Moving on to the executive team agreeing a process for providing the governing body with assurance around SEND. Claire Parker.
Sorry, John, I just took a gulp of my coffee at that point. I think we've agreed that although the SEND review was going to come back to the governing body, that in light of streamlining how we're doing our reporting, it's been agreed that that review will go to quality and performance. So we will update at the next quality and performance, and that is planned on the agenda.
Thank you. And then the next two items regarding the niche report being presented is clearly on today's agenda. Moving on to the hot topic on neurology, not urology, as Lynn has pointed out. At the bottom of this, it says action closed. Is that correct, Lynn?
Yes, and we've decided that we'll wait for those service changes to happen and then agree a future date when we will look at doing a hot topic to find out people's experiences. Perfect.
Thanks very much. And then moving to the respect, the digital respect form being recirculated to Practices for Information. Steve, I should know the answer to this, but has that been actioned? Have we got Steve with us?
Yes, it has, John. Sorry, I struggling getting me self off mute.
Oh, that's the other Steve. Right. Well, thank you. That's great. Any Stephen can answer. So that's been circulated. Okay. Have we got Steve James with us, just out of interest, because I know I'm going to bring him in early in the agenda later on.
No, Dr. Pepper, it doesn't look like he's on the call.
Okay.
Yeah.
That's fine. So we have got a digital report coming here on today's agenda, and so those two items for Steve have been covered, which is good. Now, Steve Trenchard, yes. So the primary care newsletter, the link to psychological health and wellbeing support for staff. I did try and go through the newsletters to see whether that had been actioned and circulated. I couldn't find it, but it's possibly that I hadn't seen all the newsletters myself.
Yeah, thank you, John. I'll check on that. I noticed it had been picked up at the last meeting. It might be that it's gone out in the general comms rather than the newsletter, so I'll just pick that up with comms. I know I did send some stuff through to go out around the general mental health offer, so we'll just confirm it's gone through the newsletter itself.
Thanks, Steve. And Mike, sorry, I hadn't noticed you've got a hand up, possibly from a little bit earlier.
It's I suppose I'm being a little bit pedantic, but I'm a little bit concerned about action close and what it actually means. I think I just worry about, we talk about me having things having meaning, and I know I'm being a little bit pedantic, but is the action closed or is it finished? You know, action closed doesn't mean that it's sorted out. It just means that the action shut down. You know, if it was action complete, then I would say that we'd far better to write that rather than action closed.
That's a point.
Sorry, I am being a little bit pedantic. I do apologise.
Thank you, Mike. Well, we'll take that forward. So in future, when an action is completed, we'll mark it as action completed. Right. Thank you. Moving on to again, well, this seems a duplication, doesn't it, regarding an update on SEND, which we've mentioned earlier. Just for clarification, Claire, is there a plan for, at some point in our business cycle, for this to come back to us? I mean, I know you've answered once in some terms regarding SEND. Are you going to take it to?
If it goes to quality and performance, and it's reported obviously through through the SEND strategic board, the local authorities, but Telford and Wrekin have got their re-inspection coming up soon. I would suggest that I can either report to the governing body by exception if there are any issues, or quality and performance can recommend anything that needs to be brought to the governing body, again on by exception, if that's acceptable.
Meredith?
Thank you very much. Yeah, I mean, that's absolutely fine from a QPC point of view, John. However, Claire, we did agree at Quality Performance Committee that you would be arranging something to showcase the work that's been going on under the SEND banner, including people who are actually using services and have been part of the design of the new system. I was hoping it might be this meeting, but maybe it's for the next one.
I think that's been agreed to go to the QPC, Meredith, the showcasing.
Agreed by whom?
The executive and John, when we talked about moving SEND to QPC.
Okay, thank you very much.
Does that answer the point adequately, Meredith? Is that?
I wanted to make sure that the work that's been done involving a large range of people had the opportunity to show off a bit and just show just how good it is and the difference it's making, and to recognize just the work, the effort, the energy, and the desire to make things better. So I really did think a governing body meeting would be the right vehicle for that, rather than a subcommittee where it's to a much smaller group of people.
If I may, John, I think that's a really valid point, Meredith. But we need to kind of track through the governance that we've got. So my response is kind of a hybrid of the two. So first port of call for that work would be through the scrutiny of the Quality Committee, and then with your support, Meredith, I would expect that committee will be saying, do you know what, this is a really good piece of work. We want to put this forward to governing body. So we get that balance of reporting at this level as well, because we don't want to just look at the escalated things that are troubling us. We need to see the good things as well. So yeah, support that.
Absolutely.
That sounds great. Thank you very much.
Great. If we can carry that through as an action, that would be wonderful. Thanks, Meredith. Steve?
Yeah, just to support that point, I suppose it's separating, isn't it, the requirements of the board to do governance and then the wider leadership piece on highlighting the good practice that exists, particularly in a system that's got numerous challenges. The more we can shine the light on good things, the more confidence we build collectively. So I really support that. And it might be something that we pick up this and other things that might not be in the governance route, but where there's really positive practices we pick up through comms. So I think everybody having an eye to those positive attributes in the system and projects would be a good thing.
Thank you, Steve. Moving on to the question regarding confirmation with the Palliative Care Services commissioned by SAF or the CCGs. Claire, I think there was an action.
It was subcontracted by SAF, John.
Okay, thank you. So we can complete that action. Moving on to yes, Julie, I think you were going to raise 14-day for paediatrics. Mike had raised a question with that.
And I did, and that is, we are still involved in that work, and it's David Whiting that's leading that, and I put him in touch with Mike to ensure that we continue to involve him in that piece of work. So that action, I do believe, is closed. Mike, I will check with David that he's making good progress with you.
No, nothing.
Has he not been in touch?
Nothing.
Then I apologise, Mike. He should have been. I will pick that up with David directly.
We'll keep it open for the current time.
Yeah, absolutely.
Super,
thank you.
Really. Okay. The next item on the actions was regarding Steve liaising with MPFT, and it states receiving feedback and responses, but I wasn't entirely clear to what. But Mike and yourself may be able to enlighten me.
Well, I wasn't clear either, so apologies, Mike, if I've missed something here. When I
well, no, it's hi, sorry, it's the same thing as before. You responded to us, but we've never had a formal response from the MPFT about our concerns. It may be superseded by the fact that the survey has finally come out, and some of the issues which are raised in there regarding suicide and attempted suicide may well be covered. But no, we've never ever, the practice has never received a formal documentation. I think some of these issues will also be brought up in the niche report, which I think is also relevant, which does have some bearing on the letter that we wrote. But no, we've never ever had a formal letter from MPFT regarding our concerns. Okay. So if you want to put that as they will have to be involved in the mental health survey, because the issues that we mentioned are definitely there, and they should be, and that should be taken serious. So if they are going to be done there, then we'll be happy to let things ride. But like I say, formal letter, no.
Okay, thanks, Mike. I guess my working assumption, we have had a number of meetings around the survey and trying to work through the action. So if you're happy that we fold some of the concerns that you raised, which I responded to, into the survey and the working group that flows from that, that would be great. Save us duplicating.
Just a bit disappointed that they couldn't be bothered.
Okay.
Thank you, Mike. Okay, and the next was just a correction to the minutes. Maternity. Zena, we're going to look at the Maternity Voices Partnership website, and I think there was just an action there to see whether it's live and update.
You know, and I've just realised I haven't actually actioned that, but I will. I've just sent an email to chase up on that one, so my apologies. I don't think it needs to remain on here. I will action that, and I've, as I said, sent an email to do that.
Thank you.
Yeah, the next item was also mine, wasn't it?
That was regarding relation to figures of elective versus.
Yeah, so we had some discussion at the last meeting about the rates of caesarean sections in the various categories, and I was asked to clarify that information. I've gone back to SAF because we've had a nice guidance on caesarean section issued in the meantime, and asked them to do a more detailed piece of work to consider caesarean section in the round, and I think that's probably the level of assurance we need, rather than just focusing on one particular target, because it does need to triangulate with outcomes for mothers and babies. So we've asked for a detailed report to include that, and that will go to CQRM and to the Quality and Performance Committee, and I can provide an update to this meeting when we receive that report through, and in the maternity quarterly reports to this committee, to this board. Just by way of some assurance though, at the last CQRM clinical quality review meeting with SAF, particularly around maternity, Mr. Richard Kennedy was in attendance. Now he's the external UHB obstetrician that is supporting some of the maternity governance work at SAF, and we had a detailed discussion at CQRM around the figures for caesarean sections in the various categories, and he confirmed that there was no cause for concern, and it is about triangulating against outcomes. It's not necessarily a rate in its own right that is the trigger for concern, but just warrants that further line of inquiry, really. And we did look at the detail of the data in that meeting, and there was nothing of concern to report and escalate.
Thank you, Zena. That's really helpful. Thanks very much. Okay. So the next point regarding it was a question about the use of language, I think, within the reports. Claire, you're going to have a look at the point regarding savings in neurology.
Yeah, I gave that feedback back into the team in terms of choice of language when we're looking at some of our written reports, so we can close that. We've taken that into account. Thank you.
Thanks very much, Claire. The next item is ongoing regarding quick planning processes. I don't know that you wish. Do you wish to add to anything at this point? No.
No, I suggest we remove it as an action, and we'll continue to do that.
Okay. And the next item, we certainly have a paper regarding an update against our pledges. Steve, did you want to add anything regarding the alignment of schemes with SIP?
No, just to say, John, I think this has been superseded by the ICS development, so this sits squarely in the responsibility for Nikki O'Connor, who's been working with colleagues from the CSU to align a System 1 plan. So when that's done, I think it's coming through to the Chief Execs in the next week or so. We can bring it back to the board to share.
Perfect. Thanks very much, Steve. And the final item is is on the agenda with regards to our strategic priorities. So wonderful. We'll work through the list of actions arising from the 10th of March. There were no actions arising from the 24th of March, and from the 14th of April, actions are both complete. Good. Okay, no hands up. I must remember to look up every so often to see whether any of you are asking me any questions. Okay, so we have received questions from the members of the public this month, and I understand that answers will be submitted and published on the website within 2 weeks of today's meeting. Thank you for those that have sent through questions. Right, moving into the reports. Sorry, Adam.
Are there questions that we as a board haven't seen, or have they been circulated? So we've received questions. There's going to be an answer.
I understand the question. Claire, is there a link so that the board can see the questions in advance of the answers being provided?
We can share the questions. Sandra will be able to circulate that outside of the meeting. They have come to the director so that we can construct the answers that will be uploaded, so we can share prior to the answers and then once we've developed them.
Thank you.
Great, thanks very much, Claire. Okay, Steve, we're promoting Steve to the front of the queue because he has to present elsewhere, so I hope that's all right. Steve, you've got a paper on digital tactics and strategy, yeah, thanks very much for this. If you want to give us a whirlwind 60-second appraisal of anything out of here you wish to highlight for us, it's detailed and yeah, fire away.
Yes, I'll make the usual assumption that everybody's read it, really, we were going to bring the strategy to this meeting, but actually it involves a lot more work than when we originally set out. So this describes where we are at the moment and the process we're taking in producing the strategy and the initial priorities. And the other thing I did want to highlight, because it's mentioned in the projects, the tactical projects, in giving an update on where we are with the first 2, which are due to be completed by the end of this month. The first is on the domains for general practice, which is part of infrastructure and security. As I last heard, we'd done 24 of the 51 practices and are still on target to complete it by the end of the month.
Okay, thank you.
The fibre to the premises, which is the other one, we had 5 practices still outstanding at the beginning of this week. 1 is due to go this week. 2 are being held up by roadworks because we have to get permission from highways to do them. 1 is being held up by the practice not allowing the BT engineers in, which we are trying to deal with. And the other one is held up because there's no fibre anywhere near the practice, and we're now having to look to Wales to bring the fibre through. So that may take a little while, but we still hope to have most of them, if not all of them, finished by the end of the month.
Thank you, Steve. I have visions of long tunnelling and through the hills to enable fibre to reach a practice now. So any questions for Steve? Okay. Steve, I just have one question for you really arising from this, and that was just regarding the workshops that you've mentioned. I see that one will have occurred already in April, but those coming through, are you finding that people are signing up to these, attending the workshops?
Yes, the groups who are coming to the workshop, it was very much an internal one, the first one, which we held at the end of April. So that is where we are. I suppose that took us to where we are now. The next one we will involve people from other parts of the system in the discussions. And in fact, the meeting I've got to go to and present the same where we are now is the Integrated Care Service digital strategy. They're having their first workshop this afternoon.
Okay.
So the alignment of ours to the system is very important, and drawing in what is happening in the system is very important moving forward.
Yeah. Well, no, thank you. I mean, a hugely important piece of work that's ongoing, and a clear strategy, which is good to see. So thanks very much. If nobody else has any questions for Steve, we'll release him to give his first presentation elsewhere. Lovely. Thanks very much, Steve.
Thank you.
Okay. Oh, and I suppose, yes, just coming back to that, in terms of what the governing body has asked for, we're asked to note the progress and plan around the development of the CCG IT strategy and the key tactical projects in place for 21-22. Regular updates will be provided as development progresses. Okay. Thank you.
John, it's I'd be
Mary.
very rude and just interject very quickly about a previous item. I've just been struggling with my conscience on something, and I just feel like it needs to be said. It's around the public questions. They are questions to the governing body,
Yes.
but as things have been outlined, the answers are not coming from the governing body. And I just feel that's not quite how it should be. And I'm wondering if we could quickly address that.
Meredith, I'm happy to pick that up offline and make sure that we address your concerns. That's no problem at all.
You're nice one. Thank you very much, John.
Yeah, no, that's a pleasure. Thank you. That's really important. Great. Thanks very much for that. Okay. If we move to the quality and performance, starting with the performance paper, again, as Julia's mentioned, a key member of staff was taken suddenly seriously ill, and it has influenced, obviously, the ability to provide these reports. So thank you for what you've done. Julie, do you want to highlight any particular areas? The reports have all been read, but any particular flags that you wish to raise?
Since the report was done, but actually just to update the board with regard to the neurology service that has now gone live, our new service that we commissioned from New Cross, but will continue to be provided within the county footprint. I just wanted to let governing body members know that has gone live, and so far, a few minor operational issues that we'd expect in terms of working that through, but just to give governing body assurance that the go live has gone well so far, and we're continuing to meet weekly with both New Cross and SAF to make sure that we iron out any operational issues. And what I think it might be helpful is just I'll bring an update through to the governing body in July, which we'll have been live for a couple of months then, and be able to give good assurance on that new service and the impact, which is really positive for patients. And now, as we said, because that was a kind of an urgent fix to get some capacity in a service for the county, that now we're very much focused on phase 2, which is looking to develop. We've obviously had to adopt the New Cross pathways, but to look at that and to do that more strategic piece of work with our patients and public, so that we can really shape that service to meet the Shropshire and Telford requirements. But at least in the meantime, we've got access to services for patients, and I think that's good news. So I just wanted to bring that to the governing body's attention. I think Mike's just put his hand up. So do you want me to address that before I move on?
Yes, I think happy to introduce questions now. Mike.
I thought I'd get in early, so I didn't have to. It's not that urgent. It can have waited.
Oh, okay.
But if I'm speaking, I'm speaking. There's two things I didn't understand, which I asked clarity. One is on page 3, when it says cancer weights, it says 2-week weight breast, and in brackets cancer not suspected. I thought that was a contradiction in terms. I thought if your 2-week wait was for suspected cancer, so how can it be cancer not suspected? I know that the breast clinic have not been taking anyone unless it is on a 2-week rule, but I just thought that was a bit weird.
Thank you, Mike. Can we reflect that back to Julie?
Yeah. What that is actually, Matt, there are two 2-week standards. One is overall for cancer, then we do have a breast symptomatic 2-week standard, and actually that isn't query cancer, that's just breast symptoms and breast pain. So there is actually a 2-week pathway that isn't a non-cancer pathway. That's why it's worded that way, but happy to take that offline with you if that's helpful.
I didn't know about that one, but that's fine. And the second point is, I once again have struggled with the arrows going up and down, whether they were good or bad. And the sooner we can use that linear reporting thing, I hope that will be a bit more clearer. But I still struggle to know if it is actually better or worse and what they're actually achieving with the arrows. So I think that's just me, but somehow, I don't know, I'm not sure there is a better system, but if somebody could work one out to let me know if it's better or worse, I would love some help. Thank you.
I'll pick that up with you directly, Mike. That's fine. And in terms of the making data count, that was the one update I was going to give to report. It does outline in there. We did have the conversation at Quality and Performance, and obviously we're really keen to migrate to that form of reporting, but it will take time because we need to generate, there's new data flows, new reports, and we need to get staff trained, and particularly the analysts, and that's a very bespoke piece of training that we have secured from NHS EI, but I haven't got a date for when that will be. And I also wanted to say that because obviously it's it is going to take some time, but I am keen to try and get things moving in that direction as quickly as possible. So we proposed to Quality and Performance, and they agreed that we should, rather than wait for a big bang and have everything ready, which may take some time, that we'd move it incrementally, but we do it at a programme level. So for example, we'd aim to deliver our urgent care reporting in the new format, then, you know, at some point in the future elective, and then mental health, and do it in that way, so we could make progress, but be mindful of it is a significant piece of work to manage that difference.
Yeah,
so that was just to draw that to the governing body's attention, and to make sure that the governing body's comfortable with that programme approach. And all being well, we will be able to bring the urgent care element of the report in the new format from July.
Yeah,
brilliant. Thank you.
Thank you, Julie. And I think, you know, from the non-execs discussions really are that, you know, we appreciate it's a big piece of work, but the urgency of bringing statistical process control to our forum, you know, so that we can better understand and receive assurance, that the better. So yeah, that sense of urgency is appreciated. Thanks, Julie. Donna.
Yeah, I was a bit like Mike, just getting in with some general questions for Julie, but thank you. There were a couple of things. One was right at the start of the report, which was where it suggests there'd been a marked increase in walk-ins. This is under the 4-hour A&E, particularly in the under 16s, with potentially resumption of schools. And I just wondered if, you know, when it says marked increase, what that kind of meant, and is there any sort of work underlying on what they're presenting with and how we're managing that? That was kind of my first question. And my second one was around IAPT, where the numbers are still very low. And, you know, again, I was just thinking with kind of what I'm imagining is sort of demand for these therapies out there, why we're still not achieving the target.
Okay. So first things first, in terms of the increase that we've seen, actually at the time of seeing this report, we had seen an increase in walk-ins, particularly in paediatrics, since the schools had gone back. In terms of the underlying reasons for that, we're doing a preparatory piece of work. We've obviously asked our colleagues in South for the background data. That's being discussed early next week, and we're taking that forward through the urgent and emergency care operational group next Wednesday to really get underneath what's driving that. I think it's fair to say that since we wrote that, actually across the board we've now seen an increase, and it is back to sort of pre-COVID levels, both in terms of minors, majors, and coming in through via ambulance. So that whole piece of work around what's driving that in particular is going to be understood through that group, and it will be taken forward in the first instance by that new urgent and emergency care operational group. With regards to IAPT, my understanding there is that they've done the issues with regard to the capacity, but they're still and they're actively encouraging improvement in referral rates in obviously the first quarter of this year. But they are still, although it is increasing, it's still not back up to previous levels. So I don't know if Steve may have a greater level of insight on that than I have, but that's the position I've been informed.
Steve,
yeah, thank you, Julie. As we know, we've got 2 different IAP models in the system, and we are behind in terms of our investment for the Telford one. So that's going to be a particular challenge for us this year, which we're addressing through our plan. What we're uncovering are some possible internal weights in the IAP team. And I think we've spoken before about the model in Shropshire being originally developed out of a psychology service. So as part of our transformation, we think there's a good piece of work to be done around standardising our IAPT approach so that we've got a greater fidelity to the IAP. Out of all the models in mental health, IAP should be the most simplest, but we seem to have made it a bit more complex. So that is going to be joined up in our transformation work over the next year.
Thank you.
Timescale, transformation work over the next year, Steve, in terms of address those, immediate concerns, I guess.
Yeah, well, I can take away an action to look at the particular issues in relation to performance and come back for the next board meeting. We can pick it up before that, or just on Donna, sorry, on the basis of some particular work that we can do. But I know that there is a conversation happening with Kathy Davis and the IAP team managers. Some of it relates, as I said, to the previous poor performance. There are, looking forward, there are some tricky decisions around the mental health agenda with IAPT, and whether it gets to full investment or not. We plan to at this stage, but there are some tricky decisions in relation to the wider portfolio of investment.
And maybe an interim update, certainly for the next board, Steve, would be very helpful, I think. On that would be great. Thank you. Adam.
Yeah, just on the increase in A&E activity, I assume that a lot of it is going to be parainfluenza virus, because 50% of what I've seen at Shropdock has been croup, and all the kids that didn't have croup over the winter because they weren't seeing anybody are having croup now. And that raises some questions, really. One is, do we need a public education information piece to try and discourage people from returning to activity to normal, because they all learnt to stay at home with viruses last year? And could they stay at home or go through 111 and arrive at a scheduled appointment rather than sitting in the waiting room sharing their viruses? And that particularly applies when you think about the concern about any future variant of COVID re-emerging in the midst of a sea of other people with respiratory stuff.
Yeah.
And if somebody could look at what's actually turning up in A&E, if it is a bulk of paediatric respiratory, the other question is, do we commission a service that meets that need that isn't in A&E, again, just to keep them out of the hospital and keep the cross infection rates down?
Absolutely, Adam, and that's why the right place to take that is through to that urgent and emergency care operational group to do just that, because it is understanding what's driving that demand and then take that forward in terms of what are the alternatives then to manage that in a different way.
Okay, and are you able to take that forward in that manner?
Yep.
That's great.
Absolutely.
Thanks, Julie. Mike.
Thank you. I just wanted to bring up what's happening in general practice, just so we get a context of what's happening. And at the moment, there is an exceptionally high demand on the service. Our phone system has a waiting list, but unfortunately at times it's been overwhelmed, at which point it's shut down. So, and then people have now started turning up at the practice, which I can fully understand.
Mike, I appreciate everything you're saying here, but I don't think it's relevant to the paper in front of us here at the moment.
Well, the only thing I'm saying is that there is an increased demand coming through, and if there's an increased demand at general practice, there is definitely going to be an increased demand at the hospitals. We actually aren't seeing many children, which is interesting, but I'm just trying to put it in context that it's not just the hospital that's getting overwhelmed.
Yeah. No, that's fine.
Thank you.
Thank you, Mike. Okay. Any other questions for Julie regarding the performance report. Mindful of time, if we can, the quality report next, which, Zena, is there anything you wish to highlight from the quality report?
Thank you, Chair. I will take the paper as read and also note that the Quality Performance Committee meeting minutes are attached to the papers at the end of the pack, so there is further detail. There's quite a bit of detail in the report, but I think the bits that I would wish to bring to attention to this board then are around recommencing the quality assurance visits and particularly around Shrewsbury and Telford hospitals, because we haven't been through the door as often as we would have done in a non-COVID year, and we're looking at ways in which we can undertake that in perhaps different ways. For example, on the maternity front, joining their maternity safety champion approach rather than just kind of taking the more traditional approach of doing a standalone audit. So that work's underway to engage with all providers. We have maintained our quality assurance visits to care homes in association with the requirements of the Health Protection Board for the system in any case, and those continue.
Thank you.
The outbreak position for infection prevention and control is much improved, in line with the improving trend of all things COVID, and we continue to have a close line of sight on that. With regard to the serious incident framework, the guidance that was issued by NHS England an improvement last year, which was to consider the management of SIs within timeframes at local discretion and professional judgment. We continue to do that on a case-by-case basis. And I think that the main point to raise to board is around the CQC section 31 for children's and young persons' mental health issued to SAF hospitals, and that is a system piece of work which is quite a significant number of strands to it that Steve Trenchard and I are taking forward on behalf of the CCG.
Thanks, Zena. Questions for Zena? Audrey.
Hi, thanks, Zena. Obviously, brilliant report. Just a couple of questions. I was just wondering about the maternity dashboard. I mean, I don't have to say it, obviously, but it's such a marvellous way of understanding where we were, where we are, and then obviously benchmarking against the rest of the country, or just regionally. When do you think that we might get sight of that?
Yes, so there is an update to the board a bit later on today, which gives a little bit more detail on that. But in terms of the dashboard work, we've commissioned the CSU to do that piece of work for us. Now, when we talk about maternity dashboards, many organisations have them. So we have one, SAF has one, NHS England Improvement at regional level has one, and the key thing here is to have valid data and have it all understood. A lot of the data that goes into a maternity dashboard is generated by the provider. So our due diligence on the quality assurance of that data is really important, and that's the work we undertake at the quality review meetings and other internal governance forums at SAF in particular. So when we talk about dashboards, just for clarity, as different organisations, we can be talking about different things. The dashboard that we are preparing as part of the LMNS work allows us to understand our population, maternity health and outcomes, and the various things that can and do happen in both a positive and negative way on a woman's maternity journey, and indeed the neonatal outcomes. And it allows us to cut that data at place-based level, population level, and aggregate it up in different ways. So we're hugely enthused by this work, and it's almost there, Audrey. I can't give you a final time, but it is almost there. What I'd like to do is be able to bring you a sample of that at our next maternity quality quarterly update, so that you can see what's in it, if that's helpful.
That's brilliant. That's lovely. I've got one other quick question, more around process. In your report, it talks about some performance indicators around sepsis and triaging, children's triaging, and that then is monitored through CQRM. So how does this governing board then get sight of hopefully improvements that are happening?
Yeah, so the way that the assurance feeds through to board then, Audrey, is that we have our engagement meetings with the trust, their internal governance meetings. We have sight of their CQC returns, the updates on their action plans. We also have our clinical quality review meetings to go through things in detail, and matters of escalation are discussed there. And they're also discussed at the System Oversight and Assurance Group meeting, and that's we don't cover that particular subject every time, but on a regular basis. So all of that forms our kind of body of knowledge and intelligence, and that's reported through to the Quality and Performance Committee of the CCG. And so areas of escalation from the QPC that does the detail on this are escalated to this board. Okay. So really what you see is just a synopsis. But Audrey, you and I are meeting to kind of talk through the whole piece in any case. So
yeah, lovely. Thank you ever so much.
Thank you. Donna.
Yeah, thank you, and thank you for the report, Zena. It's very comprehensive. There was just one line in there that I particularly just wanted to draw out, and I noticed that the CQC have done a report into anaesthetic cover critical care services at PRH. And I know that it says in there that there's a national shortages and that the trust is mitigating for that. Are we assured that that mitigation is appropriate and we have safe services within that at the organisation?
Yeah, I mean, this was a couple of months ago, actually, Donna. So just casting my mind back to that particular subject. So CQC also found some good areas of practice in that report, and it's a published report. It's available on CQC website. There is quite a bit of attention on medical rotas, as you quite rightly say. The mitigating actions are around rota cover, and we are confident that they've got sufficient seniority to cover the rotas, whilst not being totally compliant with the requirements of the Royal Colleges, for example, in terms of the separation of cover. But it is something that they are keeping under review. We're not seeing incidents and issues being raised as a result of that, although the CQC did note in their report there was a less of a tendency of staff to report their concerns. But having said that, when we've looked at incidents that have happened, or the incident trends and themes, we're not noticing anything that is relating to anaesthetics in particular. And just thinking forward to the niche report that's coming, anaesthetics and intensive care medicine was particularly noted as a positive area. So I think things are in the right direction for them.
Okay, thank you.
Thank you, Donna. Zena. Julie.
It was just while Zena was presenting, John, I was able to go back through my notebook and find the update to answer Donna's question about IAPT, because I knew I'd have the conversation with the team, and we'd prepped it before the last contracting meeting with MPFT. And it is that referrals are improving and are back to pre-COVID levels, and the capacity, obviously they'd taken away because they had switched off for the service in response to the original pandemic, is now fully back. So we do need to keep a close eye on it, and we are doing it now with having performance assurance manager looking at mental health. Myself, Jane and Meryl, the contract manager, do have a pre-meet before that every month now, so we can make sure we're focusing on those performance issues and make sure we make good progress there. So we'll keep you in the loop, Donna. Okay, apologies, I couldn't find that at the time.
Thanks, Julie. Zena, I just had one or two questions just to ask regarding the quality. One was mentioned that MPFT continue to request extensions for their SIs, and I was just wondering whether it was felt there was a concern of capacity here or complexity, or are we assured that we're receiving all the SIs that we should be?
Yes, this relates to my point about serious incident framework, that the NHS England has relaxed somewhat the requirements of that. And we are in discussion with MPFT about the application of that principle. We're not taking a blanket approach to extending SI submission times. We're doing it on a case-by-case basis, and MPFT have responded to that more positively in recent times and have upped their game in terms of being able to deliver those reports. We are receiving them. It was just a case of extensions and overtime.
Okay, that's great, thank you. So for those two papers, for the I'm used to taking them together. For the performance paper, we're asked to note the content of the report that the Quality and Performance Committee agreed it will take several months to develop the new Making Data Count report, and that during that time the interim reports will be a combination of old and new methodologies at programme level until all staff have been trained and all data flows are in place, and that the current actions are being taken to address the issues identified. The governing body take that. And then for the quality report, I noticed that we're asked to note the content of the report. I think possibly we should be asked to discuss and note the content of the report, but that's great. Thank you very much. Super. We'll move on to the niche report now, please. Sina.
Thank you.
We've read the entire report, so you can take it as read. But if you just want to, yes, give a brief introduction, that would be wonderful. Thank you.
Thank you. I'll bring Deborah Shepherd in as well, and we've been co-leading this work for the CCG. So this is to catch members up and the board. The niche report, the work was commissioned by the CCG as far back as 2018, and it's taken a while to progress that work for a variety of reasons, in particular around staff changes at very many of the organisations at senior level, and also, of course, because of COVID and being able to progress that work. So it feels overdue, but really, I think we should note the achievement of delivering this piece of work under these very difficult circumstances. So I will. Sorry, John, you look like you were going to.
Yes, no, I was going to say that's great, and I really want to have a really rich discussion here with this report. I think this is a a vital part of our meeting today, and yeah, so I think so yes, I'm not looking for a complete rendition of the entire report, but Deborah, if you want to come in at that point and just add anything by means of brief introduction, that would be great, and then we can get into the meat of it.
I'm not sure what I can go through sort of a summary of findings, but I imagine people will have come
That's
to
fine. Let's open it to discussion then, I think.
Could I just add, John, sorry, just before we get into the discussion, it just might be helpful to know how we handled this in the CCG. So we did have a multi-agency steering group, and there was quite significant buy-in to achieving the audit work. The reports are reporting on phase 2. The phase 1 report is with SATH, and we know that they are and have been addressing the phase 1 findings, and that will come back to the Quality and Performance Committee in due course, because I think they need a detailed sight of the response of SATH to that. It was SATH specific around serious incidents. The phase 2 was the system piece on learning from deaths. And we've met as a steering group over time, and met most recently a few weeks ago to consider the findings in detail. The actions arising were that, or the outcome of that discussion were that partners recognised the findings. I think there's been quite a bit of discussion about the findings in relation to the percentage of individuals that received excellent, good or adequate care versus those that received poorer levels of care. And I think it's important to note that in those poorer categories, it's not every element of care was poor. There were findings of some elements of poor care, which may or may not have contributed to outcomes. There isn't a causality there. It was a learning exercise that was undertaken. So I think it's important to underline that. And when we met as a steering group, we considered how we would then take forward the findings of the report. And I know you want to get into the debate of that. Alongside that is the System End of Life Steering Group, which meets regularly and has terms of reference to consider developing a system end-of-life care strategy. So this report from Niche in phase 2 will be presented to the end-of-life care group, and they will consider the findings in the development of their strategy moving forward. I think that's really important to say. So it doesn't just end here.
No, we've read that's certainly within the cover pages explaining that, and I think that's partly, Zena, that's really helpful, because that's exactly what we really want to know from this is where we take this and how it will be handled. So that's
and then I'll just hand to Deborah about the learning from death system work and regional work, actually, which Deborah is taking forward for us.
Yes, so one of the actions is to set up a system learning from deaths group. I think probably one thing I would pick out from this was that there was a lot of learning that wouldn't have come from individual organisations learning from deaths reviews, because we looked at the whole clinical pathway across organisations, and a lot of the learning came from what happens at the interfaces between those different organisations. So I think it's been a very valuable process from that point of view, and one that we will take forward in a newly set up system learning from deaths review group, which we're in the process of organising at the moment. There is also I think in the past there has been a regional learning from deaths forum which was paused, and that is about to be set up again. The first meeting's on Friday, so we'll be taking part in that and contributing and bringing back learning from it.
Thanks, Deborah. Thank you. Really keen to open this to discussion. Liz.
Thank you. So yeah, I agree in terms of it's really important that as a system we learn and we take ownership of these issues. I wanted to highlight particularly what stood out for me in a lot of issues raised in the report was around the poorer quality of care for those with severe mental illness, and that may have contributed to their deaths. In a sense, our Shropshire, Telford and Wrekin has a lower life expectancy for people with severe mental illness compared to other areas. So it's wide most places and it's wider than most other areas here. There will be a range of factors as to contribute to that. But in a sense, my question is how can we learn from the findings from this review and actually just what Deborah has said in terms of learn from it, and it is those at the interfaces of some of our systems. And I'm conscious we have a mental health group. Would that take the learning from this forward, or does it sit with the deaths groups? It is at those interfaces, but clearly I would highlight that this is, this does demonstrate some of the health inequalities that the system can support and help to address.
Thank you, Liz. And before we just take the answers, I just want to get a collection of questions and then address each one, but just get a feeling of where all the questions are. Meredith.
Yeah, thank you very much. I have to say I was very troubled by this report. I'm a lay member. I don't fully understand all the clinical aspects to this work, but 38% getting poor or very poor quality care across this, through the interaction with the system, I was very upsetting. That's not to say the 62% isn't good, and we need to learn from that as well. But it just came across to me as if the people who were in receipt of this poor care could be described as being valued less than other parts of the population. That's a bit melodramatic, but that's what comes across to me, and I just wanted to make sure that I said it in public, really, John. It's very, very difficult reading, I have to say. And the other thing I wanted just to make sure we get in all of this discussion, I understand the word learning, but changing, resulting from learning, seems to me to be more important. So if all we learn is, yes, it's really difficult and we can't do anything about it, then that's not good enough. So I would like to see a tangible change resulting from the learning and evidence and sustained. Thank you.
Thank you. And again, I'll park that and come back to it. Thank you, Meredith. Adam.
3-bit. Unmute. Bollocks.
No, we can hear you.
Sorry.
We're not at the watershed yet. We can hear you.
You can hear me. Great. I can't see anything now, but never mind. 3 thoughts really. One was, is there any benchmark? While it would be nice to have 100% excellent care, I just wondered what the societal norm was. The second one, is it 38% poor care or is it 38% poor documentation? Because the problem with paper record reviews is, if something wasn't documented, it doesn't necessarily mean it wasn't done. And the third one, and the most important one, is they raised an issue about an excess of older people being admitted overnight with poor care. And I can't remember what reason they give, but the reason I would give is that we don't have overnight care services. So we have rapid response up to 10 o'clock at night, which in practice means referrals up to about 8 o'clock at night. And we have carer in a car, but that's limited to the more urban parts of the patch, if I remember rightly. So what that means is that if you've got a stoma and you get diarrhea and you're otherwise well, and you can take your stoma bag off, but you can't put a new one on, then you will get admitted to hospital at 3 o'clock in the morning because there is no other service that can put your stoma bag on. And whether we should be looking at the volumes and looking at whether we can extend our community services overnight in the way that they are in other parts of the country.
Thank you, Adam. Really helpful. Donna.
Yeah, just a couple of points and just building on some of the things that others have said this afternoon. Again, it was a troubling report to read. And in terms of some of the individuals, the elderly, those potentially with dementia, like Meredith, I felt, we appear in some instances to be failing this group of patients and the most vulnerable. And again, in terms of what we do next, is there a training and skills issue around care for those particular those patients? So that was one. And then the other one was just, I did note in the report that it said that it was agreed right at the outset that any cases of immediate concern would be raised with individuals, but I didn't see anything in the paper from memory that suggested that had happened in any cases. So it's just around that, or any issues of candour that we needed to be aware of in terms of these particular cases that we were looked at. So that was my points. Thank you.
Thank you, Donna. Again, we'll come back to all those points. And Mike.
Thank you. Part of me was not surprised with any of the things that were brought up by the report, especially some of the discharges, as they were all too frequent during the summer last year. Certainly, people being discharged home without discharge summaries, without notification, especially in the elderly, was quite common. And therefore, 9 times out of 10, there was issues with insulin being missed because we had no notification or anything like that. I thought overall it was a very good report, and I do think that page 25 and 26, the recommendations there are absolutely spot on. My concern also, I think the mental health bit, once again, I'm sorry to be a broken record, but suicide prevention is, we have massive issues of which, and I'm concerned by the MPFT not sending through their significant event sooner than they should have done, because I think that's just a symptom. One of my colleagues' standing jokes is that consultants at hospital do not know how to fill in respect forms, as some of them seem to be atrocious with no discussions. The other thing which is also relevant is that with lockdown and COVID, some of the information parts to relatives was exceptionally poor and caused massive problems. We're picking the negative stuff here. There is definitely good stuff in there, which shows that that people in there do still care, and I think that has to be emphasised. That it's very easy to look at the doom and gloom, but which is our job. But I also would commend the fact that some of the cases documented there are very well done and very well supported.
Thanks, Mike. Okay, so reflecting back, thank you. We've got a nice variety of themes here that we need to explore. Firstly, Liz's point, how shall this learning be taken forward? Meredith and Don are asking, you know, the learning, we need tangible changes and possibly evidence coming back to board of those tangible changes, and particularly with those vulnerable groups, the elderly, those with severe mental illness, those with dementia. Will that be addressed within these within the committee that's been set up, or the group that's been set up, Learning from Death's group? Adam's point, particularly, will that group also explore the services available to people for admissions avoidance? And Mike's point, really, regarding the quality of respect forms, has that already been addressed, and will it be? Okay, so Zena, or
can I mention something else, John?
If it's
very
relevant to the
quickly.
paper, yes.
In-house services. So we keep talking, you know, what I'm not clear from the documentation is certainly about diabetes, because that's the one field that I spend my life looking at. Certainly some of the discharges are atrocious, especially with medication things. But even go back to when I was an SHO working for a diabetic firm, we used to spend our lives going to different wards. I feel that there is definitely a place for the diabetic nurse services to be expanded, and we should include hospitals or have some sort of better system in place for diabetes. And that also goes for mental health. That I think, especially with the elderly, then they also should have some sort of access to the memory service there.
I'd like to interrupt.
I can't hear you, John.
Yeah, I'm just interrupting you there, just to say that yes, diabetes was a theme in this report, and if we can add that to the response now and give Zena and Deborah and those involved.
It's more about in-house services, so that there is a team that they can call to do it, and that includes the memory service.
Thank you, Mike.
Sorry.
Zena.
Thank you, and thank you all for the questions. I think the important thing for this board to receive is assurance that work is going to be undertaken, and clearly we're not going to resolve all of the matters around this table, and neither would it be appropriate to get into the detail of each piece. I think through the System Learning from Deaths group that is being established, the terms of reference will be developed to include coverage of the recommendations of this report. Now, not everything will fit with that Learning from Deaths group, because I think what the report does show is that there are lessons to be learned that will benefit other patients who haven't died. So it's not just about those that have died, it's about how we manage medicines for diabetic patients. In any case, how we manage discharges, how we manage oncology patients that might require rapid review. There's some, if I say, some simpler work to be done. The oncology patients being an example of where a difference could be made fairly straightforwardly and possibly without too much delay, and that would make an improvement and an impact on very many patients beyond those that then subsequently demise and die. So I think this group should be seeking assurance that the recommendations are being acted on. You know, this report is presented as is at the moment, with the note that there is further work to do, and I think probably what we ought to discuss is how we then feed back to this board and dovetail with the new ICS emerging structure, so that we're all sufficiently confident that we've captured it and own it.
Thank you, Zena. Steve.
Thank you, Zena. I share the concern of colleagues reading some of the content in the report, and without getting into some of the details, there are some themes, I think, around the numbers of handoffs that people receive in the way our services are organised. It absolutely supports to be more joined up and more integrated. I think there are some messages in here about how we do things earlier. If we take, you know, Liz's view first off about the rising inequality with mortality, despite the fact that, you know, there are some statements such as abject failure around some of our care for that group of mental health. It also points the finger at the need to do good physical health checks, you know, align mental and physical health throughout all of our work and all of our pathways. So I think there are some more subtle but really important messages in here that we need to take forward as a system.
Thank you, Steve. And I wonder, I mean, I think what I'm hearing from this position is that there's a real desire here to not just read this report and for it to be another report that gathers dust, but something that comes up with tangible changes. And yes, there are some real evidence of excellent treatment, you know, initial management, ICU treatment, you know, some real positives in here. So I don't want this to be a demoralizing report, but we clearly have a lot of learning and actions to take from it. I wonder whether it would be possible to, you know, take all the recommendations, list them as they are, see how they are going to be each individually actioned and progressed, whether the, you know, the system level learning from deaths group will, you know, which parts they are able to action and which others would fall into other remits potentially. But I think it would be good to have this back and to have a look at how we are actually progressing and addressing those concerns. I don't know if any of the execs want to, you know, come back on that and say whether that's a realistic thing, whether we could have an interim report in 2 months' time as to our progress against this.
So, I mean, I think the first kind of stage of that is looking at the work that the Learning from Deaths group and the End of Life Care group would discreetly take some of these pieces. And I think you're right. There are other subject matters in there that would be appropriately attended to by other elements and other parts of our governance, both in the CCG and as a system. So I think it's for us to do as a group of directors and executives to make sure that there is capture of the recommendations in those appropriate forums, and we can certainly bring back reports at intervals for that. I'm not sure 2 months will be sufficient, John, in terms of timing. I would suggest, and because I'd say quarterly, but of course 4 months is probably fitting with the sequence of these meetings, if I may.
Thank you, Zena. Meredith.
Yeah, John, I'm just wondering, I mean, this clearly is a system-wide responsibility. I'm just wondering what the right governance line here, whether it needs to be assured by the Quality and Safety Committee for the ICS, and here for information, but the kind of the influence and accountability needs to be at that wider system level, I'd have thought, but it's just a thought.
No, it's a good thought, and I just wonder, even before Quality and Safety Committee, whether, you know, System Quality Group, because, you know, that's got that executive drive within it, really, Zena, whether this could be presented there.
And that's where the Learning from Deaths group will report into. So there is intent for this to feature on that agenda moving forward.
Okay, so we'll have that dual approach with it. We'll keep our oversight, but also run it through the ICS structure as well. Good, thank you. Claire.
Just to support that approach, really, I think it's important that we allow some time for the relevant working groups and functions within the wider system to get their teeth into it and to really start to develop the agenda. So perhaps a briefing or an update to this committee in that 4-month time period that Zena talked about, not so much to get into the detail of the work itself, because that will be being managed, but just to give some assurance that how that governance has been set up is doing what we need it to do. I think that's the really important piece. We have our natural route for escalation through Quality Committee and up to board, but I think it's important we test that we're hitting the mark in terms of what we're doing with that report.
Yeah, that's good, because what we want to do is lift up all parts of our service to those good and excellent ratings, don't we? Great, thank you. And Steve, final thoughts?
Just a final thought, which is obviously this meeting is in public and people can come and listen to it. Whether there's something that we want to do that's slightly broader on a comms piece. If people were to read the report cold as a lay person, you might be a bit concerned about what you've read. So there's something about a communication of this in the appropriate channels that provides that assurance that it's been taken absolutely seriously, that we recognise some of the good practice in here, but that we are collectively as a system wanting to use this as an opportunity to make improvements.
Thanks, Steve. I agree entirely. Lynn?
I just wanted to agree with what Steve just said about the importance of letting the public, or at least supporting the public, to understand the impact that this report is going to have on future services. And I've also highlighted in the chat bar, which I know people can't see, that Healthwatch Shropshire in 2020 published a report about end of life and palliative care, and our findings certainly supported some of the key findings in this report, particularly around the acknowledgement that people being end of life, and if that hadn't happened, the experience was much more difficult for people if it hadn't been acknowledged earlier on that they were at end of life. And because of the pandemic, we haven't had the opportunity to take that report to the end of life group. But we would still be happy to speak to the end of life group about our report, because I do think it supports a lot of the findings. Yes. The other thing I just wanted to pick up on was that as Healthwatch, we've also heard from people with diabetes that they've discharged themselves from hospitals at times because they feel that their diabetes isn't being managed appropriately and they don't feel safe. So they've decided to leave hospital in order to manage it for themselves. So I just wanted to share that with the group as well.
Thanks, Lynn. And I suspect Zena is possibly volunteering to follow that up.
I am. Thank you, Lynn. That's really helpful to know that you also have information that's going to be helpful to the end of life care group. I think I will put you in touch, and then you can take that forward, because in forming their strategy, they are seeking different perspectives and views, and I think both of the reports that we've mentioned would be important. In terms of the diabetes issues that you've mentioned, I think we can follow that up separately, and we'll probably discuss that more at the Quality and Performance Committee for the CCG.
Okay, well, thank you. I think that's been a really rich and informative discussion, and I think there will be tangible outcomes to this. So thank you all for your contributions. So we're asked to note contents of the report and the next steps for Shropshire, Telford and Wrekin system approach to learning from deaths. Thank you. If we can now...
Sorry, John. Can I just register that I don't think we should wait 4 months. This is a public meeting and people who have read it could have read the report. And I think if you leave it for 4 months, without actually having some interim report back is not good. No, I think we need a briefing at the next board meeting to know what is going on, because at the moment I'm still not sure what the questions you're asking to be done is, and I think that needs to be clarified as well. And I think that 4 months is too long. So Mike, especially public meeting. So that's just my opinion.
Thanks, Mike. So an interim report can come back. I think Zena was saying that it would take the work to achieve all the recommendations, to work them all through the system, may realistically take longer than that, but an interim update would be useful. The questions we're asking, just for clarification, are that the recommendations and the points highlighted in the report are taken to those 2 groups as mentioned, and also through the system quality governance structure to address them. Okay, thank you. So if we can move on to the finance report, please. So Laura, thank you very much for the paper. We have read it. If there's anything you wish to highlight, I think then do, and then any questions.
Thanks, John. So just to highlight really to the group that we did the final position for 2020-21 was a £600,000 deficit across the 2 legacy CCGs, and that is against the target of break even from NHS England. I think it's just important to note that that needs to be taken in the context of last year, in that we received significant non-recurrent funding because of the pandemic, and that actually the underlying position is a £71 million deficit. And that is what's been taken as the start point for the longer term financial strategy, which we'll talk about later on in the agenda. The only other point to note really is that as part of the audit process and the annual accounts, there is a section in the report where governing body members do need to make those declarations, and we do that as just approving those as part of this. That's it really, John. So any questions? Thank you.
Thank you. Questions for Laura? Jeff, thank you.
Yeah, it's more of a comment rather than a question, John. I think Laura's just gone through the numbers, and clearly the underlying issue for us is the £71 million deficit that we have got. But as audit chair and finance committee chair, I just really wanted to mention in October we were staring down the gun of about a £15 million deficit as we were exiting. And actually we got very close to break even. We actually did break even for Shropshire, a little bit of an overspend, £1.5 million for Telford. But I just really wanted to highlight the work that's been done by the execs, Laura and Claire, to get us from that position in October, £15 million deficit, down to what we did achieve. And the underlying position is still scary, absolutely get that. But through a pandemic, delivering nearly £7 million of quip savings is quite some going. So I just thought it was important to pull that out as well.
Thank you, Jeff. Thanks, Laura. Okay, well, I know we're coming on to a further finance paper a bit later, so that's really helpful. So we're asked to note the information contained in the report and also the declarations in paragraph 25. I take it that all have read paragraph 25, which is the annual accounts process and the declarations therein. And unless there are any other questions for Laura, and we're in agreement. Thank you. That's great. Thank you very much, Laura.
Thank you. So
an update now regarding a progress against our ICS pledges. Claire.
Thank you very much. Previous conversations at governing body have highlighted that we wanted to have more of a feedback loop on what's happening in the ICS space, so that we feel more included in what's going on. There are a number of us involved in lots of pieces of work, so we were trying to find a way of making sure that we give governing body oversight of all the strands of things that were going on. We've started to see an update report coming through to system chief execs, and with a view to more reporting coming through to the ICS board as well. So I'm trying to tap into that process rather than doing a job twice. Let's take one data set and share it with as many people as we can. So the report's here, it's there. I'm sure you've all read it. It highlights the specific progress we've made in all of our areas for our pledges. I know HR, there was a gap in the report at the time, but Victoria Wrekin, who's the system HR lead, has reported back to chief execs recently about the progress she's making with the work stream for HR. So I can see from my point of view that we are starting to take things forward. As I mentioned in my opening comments, we do have a more regular drumbeat now in terms of updates for the various pledges, and I'm going to use that to keep feeding that information through to governing body. So reports there. I'm happy to take any questions or comments that people might have.
Any questions for Claire? But that's really helpful, thank you. And it's a nicely structured paper as well. It gives clear actions against each pledge, which was good to read. I think very helpful having that update. Okay. So you've obviously constructed it so well, we don't have any questions for you.
I can't take the credit, I didn't write it, but I will feed back that. I will give that positive feedback.
No, but it's useful because I think one of the things we've highlighted before is making sure we have that link with what we're doing, with what the ICS is doing, our space within the ICS, as we're very much part of it. So thank you. We're asked to receive the report and note the work being done in delivery of the ICS's 10 pledges. Thank you, Claire.
Thank you.
Okay, moving into the, we've had IT strategy. So the Assuring Involvement Committee. Wonderful, excellent. Alison, I think your name's on this paper. Again, we will have read it. Is there anything you want to highlight at the start of this? I can't see you, Alison, I'm sorry. I know, Judith, you might want to come in.
Yeah, may I? Yeah, Alison and I have worked together on this. So just to make it clear, I don't want to spend too much time talking about this, but it is important. This committee, the Assuring Involvement Committee, has got the touch of the Ron seal about it. It is being set up to assure that patients and the public are involved appropriately and effectively in our commissioning activities and indeed our work more widely. So since I've been involved in the CCG, we'll often say, yes, patients and the public will need to be involved in this, and then that's all we ever hear about it. What this committee is going to do is assure on our behalf that people are being involved, that the plans are in place to involve people appropriately, that they have been involved appropriately, and that the decisions that we are being put forward have been informed by people. So this is really an important initiative, and I'd say really quite groundbreaking. Actually, this is going to put us in a very strong position in terms of our accountability to our local population, and I'm very pleased and excited about the whole thing. Appointments are in the process of being made. There's going to be 12 members of the committee. Ash and I are on it, plus 10 publicly appointed people. And Alice and I were involved in that exercise last week. And I think people will be getting letters at the end of this week to get that committee up and running. So I'm very happy to take questions about it, but I think it's a tremendous and really strong part of our kind of accountability system that has been missing up until now.
Absolutely, thank you, Meredith. And one of the points I took out of it was that those twofold roles. Partly meeting the public sector equality duty as well. Considering discrimination and needs of people who are disadvantaged. We've touched on that already today.
We have. Yeah.
And do you feel that this will link in with that and strengthen that process?
Very much so. I think the committee is going to be there to ask the question: have the people affected by these decisions, these plans, been involved in them?
Yeah.
So it's a very clear-cut question, and unfortunately, it's not always a very easy answer. But we're going to have to try and get to grips with that.
And I hadn't possibly listened quite carefully enough, but in terms of timescale of this being up and running.
I don't know if Alison's able to pick the timing up, but we'll certainly be having the first meeting, which will be a development meeting, I suspect, in the next certainly in the next 2 or 3 weeks.
So appointments have been made. We've got a full, yeah. Excellent.
Including chair and vice chair.
Thank you, Lynn.
Hi, it's Lynn from Health Watch Shropshire, Meredith. I know we've had an initial sort of email conversation about it, but I'm still keen to explore how Health Watch Shropshire might be able to support that committee, but also maybe join it and observe it in action and see if there's any support and contribution we can make to that piece of work.
Yeah, brilliant. Thanks, Lynn. Absolutely, that there is definitely a relationship to be had, and I think we wanted to put it to the committee itself to be able to discuss it and indeed invite Health Watch Shropshire and Telford and Wrekin to explore that relationship. So thank you.
Thank you.
And Sina.
Thank you. I just wondered how this new committee and it seems a very good cause actually, how it fits to the system governance arrangements moving forward, or are we setting something up that would end on the 31st of March next year, or will it step smoothly into something else?
I believe stepping smoothly into the system place is where it's going to be going. That's my that's where I want Zena. Obviously, just because I wanted, I can't make it happen, but that is certainly where I'd like it to go, and what we've been thinking about, and I would certainly like to pick it up with the ICS leaders, because we're talking about the same population. The population that the CCG relates to is the same population in the main that all the other parts of the system relate to. So when it comes to involving people, I think we all want to have that as joined up as we can do. So smooth relationship with the overall ICS system is absolutely where I'd like it to go.
And Deborah. So you're on mute, I'm afraid.
Sorry, I don't know what's going on there. I think this is really exciting and encouraging. I think you're right, Meredith. You've hit the nail on the head. We often talk about intending to engage with the public to get their opinion and their input, and definitely wanting to do that, but sometimes the practicalities and the logistics get in the way, and it seems really difficult to do. So this will be a really useful resource. I guess my question was a practical one. How do you envisage this working? Do you think that we should be bringing projects to the committee? Would committee members be available to take part in some of the development work that we're doing? How do you envisage it working?
That's a very good question. Yeah, just to be clear, the committee is there to assure, it's not the involvement method. So the way I think it will work is that a piece of work will be instigated. One of the first steps to be taken will be to go to the Assuring Involvement Committee to say, we want to involve people, a range of people in a range of ways. These are our ideas. This is how we'd like to go about doing it. What do you think? Any advice, any suggestions? And then to bring that back at the halfway point, maybe to say, well, this is what's happened so far. This is what people told us. Now we want to involve people in the design stage of the work, or to option appraisal, development of proposals, and then to go away again, and then to come back at the end of the exercise to say, well, this is all the work that we've done. This is what everyone said. Are you happy with the way we've gone about it? And can we take it to the governing body now, or something like that? So it's going to be a check, support and challenge type of arrangement, but the committee is not the involvement method itself. It's to assure the involvement.
Thank you. And final question from Steve.
Yeah, thank you, Meredith. I know we've had a couple of chats about this one, and I think it's a great time. There's a lot of discussion in the broader system across health and care and in the partnership boards about a commitment to co-production and active involvement in everything that we do. And I think just to inform the board that we've already agreed that we want to engage people in the way we do the involvement. So we've got some initial plans to capture and scope the good involvement that's already happening that we can learn from across all our transformation schemes. So absolutely, we'll have a forward rolling programme of people that come through to the Assurance Involvement Committee. Some of the examples that we've got, you know, the maternity voices, the work in SEND, some of the local authority work it's up there with some of the best, but it's not like everything, it's not routinized and consistent, and that's what we are aiming to get to.
Yeah, great. That's lovely. Thank you.
Well, this has been a real highlight of today's agenda, I think. So thank you very much, Meredith.
Thank you.
So we're asked to note the role and remit of the Assuring Involvement Committee as outlined in this report. Thank you very much. I think we do. So mindful of time, we're roughly half an hour behind schedule. So you've already lost your 10-minute break. If we could then move to the CCG mission statement and strategic objectives, which we've brought back after rewriting and rewording. Does anyone want to ask any questions regarding this? I'm slightly anxious. We didn't hear. Oh, apologies, Liz. Liz, I didn't see a hand. Liz.
Thank you, John. I did want to make a comment on the inequalities, health inequalities
yes.
Phrase, which I'm sure it's not meant, but it feels a bit like it's about where and when services are planned, and not the how, which clearly is an admission. So I would want to recommend that we change that to something like to reduce health inequalities by making sure our services take a preventative approach and take account of different needs, experiences and expectations of our communities. It feels a bit like this is just about planning where and when services should be delivered, and it's far more than that.
Meredith.
Thank you. A couple of points, if I may. One is just to clear about the language. I think the paper refers to strategic objectives and then separately strategic priorities. I just want to make sure we stick to one or the other. I think they're priorities myself, but there's that. Secondly, the discussion we were having around the niche report really did seem to resonate with me in relation to our mission and our strategic priorities, in that we talk about everyone in this language, and yet the niche report was clearly indicating that perhaps we don't really mean everyone when we say everyone. So that was just an important reminder to me. And then finally, I was talking to a very wise man earlier today, and he was saying we should always make safety our #1 priority. And I was struck by the fact that safety didn't appear in the language here. I know safety, it comes under the notion of quality, following the Darcy review, but I did wonder if we ought to pull safety out or highlight it somewhere.
Claire, do you want to come back on Meredith and Liz's very valuable points there?
Yeah, absolutely. So, Liz, yeah, take on board your comments completely. I think that more rounded description feels far better in terms of our intent, so we don't mislead with poor choice of words, I suppose. So I'm quite happy that we can redesign and remove the when and where and make that reference to the preventative approach. So that's really helpful, thank you. Meredith, take your point about strategic objective or priority. I think we do need to be consistent. So yes, these are our strategic priorities. Just to link it back, this is what forms the foundation for our board assurance framework. So we will have those priorities listed at the top of that assurance framework, and we will then map our risks and mitigations and give our assurances against them. So that's absolutely fine. In terms of your point on safety, yes, I'd be more than happy just to add the word in, to be honest. So in our strategic priority #5, at the moment we say to ensure health services we commission are high quality, sustainable and value for money. It's quite easy for us to insert that word to say high quality, safe, sustainable and value for money. I don't think that detracts from the message that we're trying to give there.
Thank you.
Thank you.
So unless I think so long as people are comfortable in terms of, if the board is comfortable in terms of taking Liz's amendment and Meredith's suggestion as well, if we're happy collectively that those amendments were made with Claire, then I think we can at this point adopt that.
That'd be brilliant.
And also, I think one thing I'd quite like to add is if we could try and reference our priorities against the papers we bring to board as well, to make sure to see how the workings over the year align to our priorities, and to see, to reference the priorities as we bring papers through.
Yeah.
Okay, thank you. That's grand. So if on those provisos and amendments, we're asked to approve and adopt the mission statement and strategy corrected to priorities outlined in the report. Okay, thank you. So moving on to a verbal.
Sorry, John, apologise for interrupting, but I'm getting messages from Sonia about joining the next meeting. So do we need someone to let her know that it's been delayed?
Are you able to reply to her, Mike?
It's Alison. I'm in the office. I'll walk down and tell her now.
Thank you.
Brilliant. Just thought, otherwise, because it just keeps flashing up.
Thank you, Mike. That's great. Thank you. Sam, are you with us for a verbal report at this point for the operational plan?
I am, yes. So just to give you a bit of a position statement in terms of where we're at and the next steps, following on from updates that you'll have received as the governing body group previously. So just to reiterate the context, we're in a very unusual planning round this year, given some different timescales that we're working with, largely as a result of COVID knocking the timescales on. And also condensing those to a degree as well. But we're also, for the first time, completing the planning round as a system rather than as individual organisations. So quite a different beast this year. You'll be aware from previous updates that NHS England, as they usually do, specify a timetable and the number of elements of the plan that need to be submitted in different forms at different points. The first major milestone was a draft narrative plan along with a finance plan and draft activity information to be submitted on the 6th of May. So I'm pleased to say that we have completed that. The system has pulled together enormously well to populate quite a difficult template. But we have completed that as a draft and submitted that. We are expecting feedback from NHS England at our review meeting tomorrow. And we'll then continue to work towards refining the plan for final submission on the 3rd of June. So in terms of next steps, although that initial sort of interim piece has gone forward, we've continued to work on the plan as a system. As it is a system plan, we will be submitting that to the ICS board on the 26th of May, ultimately for system sign-off, as you would expect. But leading up to that, we will be looking at how we might best sign that off as a CCG as well. So I'll be linking in with you, John and Claire, subsequent to this meeting to just finalise those steps for the CCG. But really just a temperature check at this stage to say that everything's on track. It's where we would expect it to be at this point. We're clear about the work that we need to do to move towards that final submission, with the caveat, of course, of any feedback that we get from NHS England in due course. So I'll be succinct and leave it at that.
Thank you, Sam. Excellent. Good. No hands up, so that's great. Thanks very much for that update, Sam. If we can move then to the 2021-22 financial plan, back to Laura.
Thanks, John. So as Sam said, obviously the financial plan went as part of that overall plan on the 6th of May. I'll assume that the paper's been read. It is still very complicated in terms of the financial arrangements. We do have temporary financial arrangements in place for the first 6 months of this year because of the ongoing pandemic. But I think what we just need to point out is that what's really important is how we're delivering against the recurrent sustainability plan that's being drawn up across the system. The H1 plan is simply a 6-month plan within that framework with a separate funding envelope. The most likely scenario at the moment for H1, so the first half of the year, is a £6 million system deficit. And just to say that in terms of our overall system sustainability plan, the focus for us, as well as the system, really needs to now be around those efficiency plans and developing the big 6 in terms of transformational savings for the system across the future years. And that's where we're kind of focusing all of our efforts at the moment. And Steve's team are obviously leading on that process and have set up some internal governance around that to try and get some pace going with that as well. So just happy to take questions, John. Thank you.
Thanks, Laura. Claire.
Thank you. Just to support Laura really in terms of what she's just described. So when we produce our financial plan, we're having to do that as a system as well as an individual organisation. So there have been quite lengthy discussions about what to do with the £6 million deficit. So we're asked to deliver a break-even plan. We've been very careful to articulate collectively why we don't think that's possible, and certainly a good chunk of that does sit with the CCG, in fairness. So in reporting terms, to meet the requirement, we've set a plan for break-even, but we've also put in a supporting narrative that describes the £6 million risk that we have for the first half of the year. Now, the conversation that we had at execs, and which I supported, was that we would make the adjustment for break even within the CCG position. Now, I just wanted to give some comfort to governing body members. That was not me agreeing to take on the problem of £6 million for the CCG. This is just a place to park that position whilst we do our system reporting. So when we look at our results, we will be considering as a board our CCG results, and also Laura and the team will report the wider context then in terms of the system position. So all chief executives agree that management of that risk for the system is a collective responsibility. It's not just one for the CCG, and I think that's just really important to point out for board members.
Yes, amazing, thank you. Jeff.
Yeah, I suppose I just really wanted to add to the recommendations for board to consider. I think the four that we're asked to note are fine. I suppose what I would do is just, I suppose, go back to the letter of the 5th of March from NHSEI, where they were very clear around their expectation of each of the constituent parts of the ICS delivering their 3% target, and currently in H1 against the £6 million gap, we're £4.9 million of that. So, you know, we have got some work to do, and clearly, like every financial plan, the longer it takes to plan the things that you're going to execute, the less impact that you get in the year of actually delivering those changes. So I think, you know, we're obviously doing a lot of work in the finance committee, and I'm getting a lot of support and activity from the execs and support. But I do think that, you know, there is an urgency here against the backdrop of that 3% that we shouldn't ignore, and perhaps some of the issues we're asked to note probably need to be a little bit clearer around what we have got to do, because very soon we'll just be looking at half-year impact rather than full-year impact, and that just makes the number of activities or some of the difficult decisions even more harder to conclude. So I just really wanted to do that, and if anyone hasn't seen the NHSEI letter, it may well be worthwhile having a read of that.
Laura, do you want to just come back in on that in terms of the Jeff's point regarding what we're asked to note here? I'm not sure, Jeff, whether you've spelt out an additional wording that you would wish for the governing body to take up with this, but
I think, yeah, I note what you're saying, Jeff. So I think in the final recommendation where we note progress and next steps to develop the sustainable finance plan, I think we just need to draw out there that the key focus for us is around delivering that, working towards delivering more against that 3% target, and really making sure we've got the resource against the big 6 for the future transformational savings. And we can add to that. That's fine, Jeff. Yeah.
Okay, thank you. Adam.
Just that at the moment it seems very straight line and top level, and I sort of have this angst that each year we'll be looking at a 30 million quip and going, oh, I wonder where we can find that, and that bigger chunks of saving are going to take longer term system redesign and need to happen over years. So turning that into a more realistic structure over time would be nice, please.
Yeah, so I think in terms of that one, Adam, I think everybody's recognised for this financial year, the plan is literally about sustainability and maintaining the level of spend that we've seen in previous years. What we need to do is work this year on those big 6 transformational savings and anything else that comes out that we can work on to get that delivering from next financial year, and that will take full system buy-in and system redesign, and Steve's team are working on each of those schemes individually.
Okay. Steve.
Yeah, just to say that I fully support your concerns, Adam. And one of the things that we talked about only this morning actually was adding to our the way we run our or will be running our sustainability working group is next year and the year after. What we're in the process of doing through supporting the Big 6 is to pull out a plan on a page over the 5 years. It's very easy, particularly with the consistency and speed of ask from the national teams to the system, to be focusing on the here and now, the here and now, the here and now, rather than years 2, 3, 4, 5. So this is a 5-year plan. It is tricky to think beyond 18 months, 2 years. Just naturally, most strategies deal with the first stuff, and if you see most implementation plans, they're always front loaded for the first year, and then it's like, what are you going to do 2 years, 3, 4, 5 years? So we've got to do that and make it realistic. I think then the challenge, and we've seen this in the MSK Alliance, is getting on board our finance colleagues, our performance colleagues, understanding the activity, understanding the changes, thinking about the impact for those, so that there's a very clear gateway before we get into thinking about redesign, that there's confidence in what the redesign is going to deliver. So that's the bit where we're getting support from the national team, looking at the benchmarking data, the system data, and comparing that across what we're finding nationally in terms of the programs of transformation. So this is a year of stabilisation and planning to get to that longer term view.
Okay, thank you, Steve. So we're asked to approve the H1 plan submission to be used for the CCG budgets for the first half of 21-22, to note that the CCG is holding the 6 million system adjustment to break even for H1, to note the level of risk inherent in this plan, and also the progress and next steps to develop the recurrent sustainable finance plan across the system, with the addition of Jeff's real request here that there's a key focus on delivering more against the 3% target. Okay, thank you, Laura.
Thank you.
So the governing body annual cycle of business, Alison, thank you for providing this. I think it was well presented in a graph form. I don't think you probably have to talk us through this one.
No, I wouldn't. I would hope not.
If we start with questions, and if I can just ask about the flu plan, I noticed that is highlighted to be in November, and it's on the first page of the table under planning and restoration. Is November realistic time to be starting or presenting the flu plan?
I will defer to Sam if she's still on the call, because obviously she'll have the detail.
Yes, I mean, I think we've made an estimate really, John, in terms of when that will be prepared and when it falls in terms of the business cycle. Obviously, we can make adjustments to that. At the moment, we're expecting some complex planning in terms of how it's going to align with COVID. We're still awaiting guidance on that. So I think we've hedged our bets in terms of the best point at which to land that. We can certainly pull that forward if we're in a position to bring that 2 months earlier.
Yeah, that's great. I mean, I was just thinking it would be awful if we were behind the curve on that, because flu's often up and running by that point. So yeah. Thank you. Any other questions regarding the annual cycle of business for Alison? Okay. Thank you. That's useful to have so that we can see what lies ahead, and clearly a structure that's being followed. So thank you. Oh, and yes, and we are asked to approve for adoption the governing body cycle of business attached to the report. Zena.
So sorry, Chair. I was just looking through, and Alison and I have sort of discussed this. I just think LMNS needs to feature on here discreetly, actually, and I think it's probably an oversight that it's not on the plan. So I think it should be the quarterly updates we receive on maternity is a report from LMNS, because the CCG would still need to be cited on that. Sorry, Alison.
Okay.
That's fine. And with that addition, that's wonderful. Thank you. Okay, so we now have a series of adoption of key strategies and policies, which we've put together in the agenda today. Alison, do you want to just give a background on this, and then we can open it up to any questions?
Yeah, so the report is split into three parts, really. The first part is presenting a number of strategies, three of which were developed through the application process to transition to a single CCG. And I think for some of those, they are a narrative of at a point in time. So, for example, the communications and engagement strategy, clearly that was only supposed to be for a year's running, because our intention due to COVID was to properly design and develop a full strategy that would last us for 3 to 4 years. But because of COVID, we had to put that on the back burner. So we defaulted to a 1-year strategy. And of course, now with the presentation of an ICS, a statutory ICS in a year's time, it makes sense to just hold with that to see us through our running over the next 12 months, because the ICS will be developing a ICS communications and engagement strategy over the coming months. So we've obviously, we're proposing that we adopt that as it is now with no further work. Again, the commissioning strategy, Sam can talk to that in more detail, but that has been developed over the last 8-9 months as part of the application process. But the idea is obviously that will morph into an ICS approach to commissioning going forward. And the organisational development strategy, that was used during the process of application, with some work still ongoing at the moment with staff and line managers, which I've outlined in the strategy itself. It's a strategy and a plan. And the risk management strategy, we took that to audit committee last month, and it was approved for support and recommendation to the governing body. It's based on a hybrid of both Shropshire and Telford and Wrekin CCG's approach to risk management, and again is written for use over the year. And then we've got the two policies that are statutory policies that we need the governing body to approve, that audit committee has seen. And then finally, just taking the discussions we've had previously around policies generically, I've outlined for you the policies that will be, by the end of this month, approved either by a committee or this governing body today, and those that won't. And a recommendation that we adopt wholesale those that are coloured in yellow to bridge the interim period we have until those policies can be reviewed and realigned.
Thank you. That's great, Alison. Thank you. Meredith.
Thanks, Alison. Yeah, all very good. An enormous amount of work has gone into this. It's obviously self-evident that someone must have done the work. I know you did it, and your colleagues have done a huge amount of work. So anyway, thank you. Just wanted to make sure that, although they are at a point in time, that we do update them. So, for example, the comms and engagement strategy. There are some elements of it. There's a tense issue, but also our mission and strategic priorities and so forth can all go in there and be brought up to date as much as possible. But the other thing that's really struck me is that I wouldn't mind betting a very large proportion of what's in these documents it's not for me to say, of course, but will comfortably form the basis of what we have in a year's time for our ICS, or the development of our ICS policies and strategies. So I really hope all this work is underpins and supports that transition into those new systems and structures. Thank you.
Thank you, Meredith. Donna.
Meredith stole my thunder. I was going to say precisely the same with regard to just somebody needs to do a quick sort of marry up if we are adopting that, because we've just changed some of our mission and vision, etc. So it needs to reflect that. And just, I suppose it's just it seems to be a gap in some of the things around it for our ICS, which is what's happening with primary care commissioning in our delegated functions. It doesn't ever seem to be in any of the diagrams or structures and sections, but that may be just because it's not fully developed yet. But
you want to come back on that point?
I think it's a really good point. I probably am not in the best position to answer this, but my view is that I think the ICS probably is trying to focus on those things that are within its sort of control in terms of commissioning, and primary care delegation is just that, it's delegated. So obviously the statutory responsibility remains with NHS England, so our ability to vary is severely limited. We have to follow the guidance that we get from them. So I think in terms of policies and strategies, probably what you're seeing, Donna, is a bit of a time lag with primary care, because there's less room for manoeuvre, and we're limited in our development of that at the moment. Clearly, we're still waiting for the legislation to come out to see what that means for primary care and the other primary services that NHS England currently commission.
Okay, thank you. Deborah.
Thanks. Two things. I wonder if Claire wants to come back in on the primary care issue. Mine was a completely separate one, and it's a small thing. Just looking at the medicines management policies, there seems to be no consistency between those which are published on the website and which are not. I wonder if that's just a carryover from different habits or policies in the two previous separate CCGs in what they put on the website. And whilst most of these may not be statutory requirements, they're actually really useful references for clinicians. So I wondered if the publishing parts could be reviewed, and in most cases, unless there's a good reason not to, whether they should be published as a clinical reference.
Point. Thank you. Perhaps we could take that one away. Alison.
Yes, I think that's a really good point.
Yeah. Claire.
Yeah, Deborah was reading my mind. Oh, sorry, Claire S or Claire P?
No, go on. After you, I've got a different point. Okay.
Thank you. Sorry, it was just on with reference to the primary care delegated powers. I do think we do need to pick up those policies, Alison, because my colleagues will know that I kind of rant in the ICS about primary care as a statutory function, and where that sits very clearly in the structure until we've got the legislative frameworks. But I think we need to be really clear that the policies that we've got now as joint policies for the CCG need to stand until the legislation changes, and that won't get enacted till the 1st of April. So we do need to make sure that's really clear. But I'm really happy to take that outside with Alison, and then make sure that those policies will go through Primary Care Commissioning Committee in line with our governance as a CCG.
Perfect. Thank you.
Thanks. Thank you. Just of the suite of strategies that went through our application process, the one that's conspicuous in its absence in this list is the finance strategy. And what I didn't want people to think is that we've just forgotten that and left it behind. We took a judgment not to include it because the world has moved on fundamentally since we submitted a document as part of our suite for merger. So rather than make public a document that I couldn't or Laura couldn't ask for us to ratify because the world has moved on, we've left that out of this suite. Also because we're planning through our system work at the moment to be bringing something back in the next couple of months anyway. So rather than create more confusion, we've left that off, but I just wanted to give assurance that that hasn't been forgotten.
Thank you. Thanks, Claire. And Liz.
Thank you. Really well written, an easy read. So that congratulations to those who've written it. For me, I felt the children's or the best start in life agenda wasn't strongly enough articulated within the document. We've got children's physical health under community and place-based care, and then we've made reference to all age mental health in the mental health section. And it just didn't feel that it was strong enough in terms of how we've written this document in terms of children's health. And also, forgive me, I might have missed it, but in terms of the work on LMS, the maternity system isn't in there either. So with a fresh pair of eyes, I don't see that we've got the best start in life adequately reflected.
I'll take that away, Liz. Thank you.
And these are documents that we can adopt and adapt over time.
Yes, absolutely. I mean, the adoption at this point in time is adopting what we've already had in the past, but clearly we've got a plan for moving those forward. So either we review and adopt them as they are, or I think, as Liz is suggesting, that actually the review is more wholesale in terms of looking at what we should have now, rather than looking retrospectively back at what we had previously.
Yes. So do you two want to?
I'll pick this up outside with executive colleagues, because I think it probably cuts across different directorates.
Yes. Okay, thank you. And Lynn?
Hi, thanks, John. Just a comment, really. I suppose, and I have put it in the chat bar, I would have, in relation to the comms and engagement strategy, I would have liked to just see a more explicit reference to Health Watch within there. We are mentioned under patient groups, but then later on in the document, we're not listed as one of those groups, essentially. And I just wonder if, you know, the role that we provide in supporting the CCG with assurance in terms of the reports we produce doesn't set us slightly apart or make us slightly different to the other patient groups that are listed. Okay. And the other thing I was just going to point out that quite often the word co-production is used across the system in strategies like this, and I noticed that it isn't in this strategy, and that may be because there isn't co-production with the CCG, but I just wanted to make that observation that I hadn't seen it in there.
Yeah, that's a really good point, actually, Lynn. It hadn't even occurred to me that it wasn't in there, so I will have another look at that. In terms of actually making the role of Health Watch more explicit, I totally agree with you. I'll have a look at that. If governing body are happy to approve that with that amendment, I will go back and realign so that we've got Health Watch more prominent and that your unique role is more clearly defined.
Thank you.
Thank you both. Deborah, is that a historical hand or a new one?
Sorry, historical.
That's fine. So, Mike.
I thought Adam was first.
I don't see Adam's hand.
It's on my screen, but I'll...
If it's there, it's not meant to be.
Oh, sorry, mate. I thought the report was very good. I think there still needs work on it. The issue which has been brought up by Donna was about general practice and primary care, but we knew but that's always been a sticking point, especially with the ICSs, that they still doesn't seem to be how it fits into the jigsaw. My comment was actually about community place-based care when they were talking about left shift, and being a GP in my other job, I always start worrying what left shift means. So although primary care is not mentioned directly here, there is always going to be a knock-on effect, which where general practice may well end up being affected. So I would suggest that there is still a place for looking at primary care here, because there can be consequences for some of the things that happen. But I think for a piece of work it's very good, but it still needs fine tuning. I think is the right way of describing it. But well done, Alison. Thanks, you.
Mike. I'll take those comments on board. Thank you.
Okay. So thank you all. There are 4 recommendations and actions required in the paper. Alison, there's some suggestions of amendments to be made, and I don't think we've heard any objections to any of the suggested amendments and actions that you're taking away. So, with the proviso that they are actioned and addressed, if the governing body is happy to approve and note the policies of the 4 recommended actions in the paper, I think we can say that is complete. Okay, thank you very much.
Thank you very much.
Super, and thank you for all the hard work, Alison, that you clearly put into that. So then we now have, for information, so the other committee reports are included for information. Okay, and then moving on to any other business. I've not been informed of any other business. Okay, so therefore, thank you all. The date and time of our next meeting is proposed to be the Wednesday, the 14th of July, 21, time to be confirmed. So to resolve that representatives of the press and other members of the public be excluded from the remainder of the meeting, having regard to the confidential nature of the business to be transacted, publicity on which would be prejudicial to the public interest, section 1(2) of the Public Bodies Admissions to Meetings Act 1960. Thank you all very much for all your contributions.
So what